Hello people, this is Dr. Muskaan this side, and today I'm going to discuss very interesting case because patient has came with the complaint of hyponatremia, which was known to them as a concern, and later we came to know hyponatremia was not the major cause. There was another disease, that is adrenal insufficiency. There was low cortisol levels, and hyponatremia is one of the sign of adrenal insufficiency. So it is very interesting case, and let me take you towards journey of this case. Here is 55-year-old female who has came to ER with chief complaint of talking to herself and listening voices since one day, plus faint from the morning. On arrival, ABCS was done, airway was patent, breathing assessment was normal, circulation assessment shows hypotension, sensorium was alert, GCS was 15, E4, V5, M6, that was eye was opening spontaneously, verbal response was oriented, and motor responses, she was obeying the commands. HOPI patient was apparently asymptomatic one day back when she started complaining of muttering to herself, irrelevant talks, and listening to inexistent voices. She was diagnosed with schizophrenia in 2021. Her treatment was started there and then. Patient also complains of decreased appetite, decreased sleep, and irritability. Past history: she was known case of hypothyroidism, hypertension, psychiatric illness, and cholelithiasis. Negative history: no history of fever, seizures, convulsions, chest pain, urinary incontinence, bowel incontinence, shortness of breath, cough with sputum. Past medical history: she was on medications such as Thionorm, hydrocortisone, clinidipine. Clinidipine is calcium channel. Risperidone, which is for schizophrenia. Plus for schizophrenia, she was also taking Shizodone, Zapig tablets, and clonazepam, which is for anticonvulsant and induces the sleep. Plus she was taking high salt intake for curing her hyponatremia. Personal history: sleep was inadequate, she takes vegetarian diet, there was no addiction of smoking, alcohol, bowel, bladder habits are normal. General examination: decubitus, patient is conscious, oriented to time, pleasant person, she is lying comfortably on bed, and cooperative. Vitals were within the normal limits. Pickle, that is parallel icterus, clubbing, cyanosis, edema, lymphadenopathy were all absent except parallel, which was present. Investigation picture shows CBC hemoglobin 10.2, which shows anemia. KFT picture shows electrolyte disbalance. Sodium was 114, potassium was 3.2, and chlorine was 84. LFT picture shows SGOT, SGPT slightly raised, which shows serum transaminitis. ABG picture shows metabolic alkalosis. Lipid profile shows high cholesterol levels. Thyroid profile shows decreased T3, T4, and normal TSH. Further, cortisol levels were done that was less than 18 mg per dl. Just 1 minute. Yeah. So for the last diagnosis here is adrenal insufficiency, and one of the cause of adrenal insufficiency is sign is your hyponatremia. And at the end, I want to tell you the difference between hyponatremia, chronic hyponatremia, and adrenal insufficiency. So let's start with adrenal insufficiency. So it is of two types, primary and secondary. Primary means there is some problem in adrenal gland, and secondary means there is some problem in your CNS. If there is problem in adrenal gland, the causes might be Addison disease, infection, HIV, TB, your CAH, that is congenital adrenal hyperplasia. But if there is any problem in CNS, which is secondary, there can be some trauma or tumor which is associated with pituitary gland, which is causing decreased levels of ACTH. Now, features of adrenal insufficiency: if it is acute, the features are shock, decreased aldosterone levels, and decreased aldosterone levels decreases your sodium and increases your potassium, that is hyponatremia and hyperkalemia. Treatment which is given for acute adrenal insufficiency is IV fluids and injection hydrocortisone, which was practically given in the patient I'm telling you. If there is chronic adrenal insufficiency, there is decreased glucocorticoids, hypoglycemia, and lethargy. These are the features of decreased glucocorticoids. If there are decreased mineralocorticoids, there can be postural hypertension and salt craving. Now, further, what is your schizophrenia? Schizophrenia says 4 A's, that is autism. Autism means being alone. Ambivalence, which is inability to decide. And affective flattening, which shows no emotions. And association loss, that is thought process loosened, causing disorganized speech. Now, what is your hyponatremia and chronic hyponatremia? Hyponatremia, normal values lies between 135 to 145 milliequivalent per liter. But if it is less than 135, it shows hyponatremia. There are gradings for hyponatremia, that is mild, moderate, severe, and very severe. Mild hyponatremia is 130 to 134. Moderate is 120 to 129. Severe is 100 to 119, and very severe is less than 100. So my patient has sodium of 114, which lies in severe category. What are the features of mild, moderate, and severe hyponatremia? Mild hyponatremia features are only GI symptoms, that is nausea, vomiting, anorexia. Anorexia is a feeling of overweighting. Apathy, which means no interest. Headache and lethargy. Lethargy is tired and no energy. Symptoms of moderate hyponatremia is neurological symptoms, mild headache, lethargy, and predominantly GI symptoms. And symptoms of severe hyponatremia is neurological symptoms such as gait, ataxia, confusion, disorientation, and psychosis. In my case, there were evidence of hyponatremia, severe hyponatremia, which was present in the reports of the KFT, that was 114 milliequivalent per liter, but there was no clinical evidence for it other than confusion, which was present in the patient. Further, very severe symptoms of hyponatremia shows the features of raised ICT, that is stupor, coma, pseudobulbar palsy, tentorial herniation, kinestokes, respiration, and death. And chronic hyponatremia. What is chronic hyponatremia? When patient has hyponatremia for 2 days, body goes into compensation phase, brain excretes out solutes into CSF. This increases water concentration of brain cells with respect to blood. Water diffuses back into the blood due to the reversal of the concentration gradient. Reduction in the brain size occurs to midway between normal and previously swollen size. Management of chronic hyponatremia is patient presents for more than 2 days. History of hyponatremia, cause is uncertain, time of symptom onset is unknown. We have to check for seizures if they are present or absent. If they are present, no compensation phase yet, so that is acute hyponatremia. But if it is absent, the seizures, check for sodium levels. If they are less than 120, that means there are neuro symptoms present. Just give 3% hypotonic saline solution around the clock. And if it is more than 120, check for hydration status. In checking of hydration status, just check for the signs. There are 3 things, that is hypovolemia, hypervolemia, and euvolemia. If it is there hypovolemia, that means signs of dehydration are present. IVC diameter is low and collapsible. Just start on 0.9% NS till IVC is well appreciated. That is your inferior vena cava, which will you see on POCUS. Hypervolemia, just give diuretics, salt restriction, and Vaptins. In euvolemia, there is no major neurological symptoms. Consider it as SIADH, syndrome of inappropriate antidiuretic hormone. Just do fluid restriction and give Vaptins. So the treatment of less than 120 milliequivalent of sodium in the body is 15 to 30 milliliter per hour, 3% hypertonic saline, and 600 ml of fluids per 24 hours, that is 6 drops per minute. And in my patient whose sodium was 114 milliequivalent per liter, treatment given was salt capsule and IV fluid NS at the rate of 80 ml per hour. So that's all. This was a really interesting case, and the antibiotics which were given on this patient were Thironol, Pan, hydrocortisone, salt capsules, Shazadone, and Etilam. I really enjoyed learning on this case. I hope you have also enjoyed listening to the history of this patient. That's all. Dr. Muskaan is signing off now.